Okay, well, I hope you had a nice little break. I gave you all a few minutes to go to the bathroom or refill your adult beverage or whatever you needed to do there, because I definitely needed to stretch. Being in the library is kind of weird. You got people walking by the door and they stare in at you and you just want to go, hi, go away. But anyway, I apologize. I'm beyond myself there. Going back to our topic, elements of the nurse-patient relationship, nonverbal. Like I said before, one cannot not communicate, and we need to help them tell their story. But we have to remember that there's a couple of things that will stand in our way. The first 5 minutes, they're going to tell you what they want to talk about. If you miss that, then you're not going to be working with them. And they may say it several times. You walk in, you say, hi, my name is Tom, and I'm going to be your student nurse today, and I want to talk with you a little bit. And they say, oh, okay, as long as we don't talk about my stepfather. And you say, oh, that's fine. And then they say, oh, my stepfather, he is just terrible to me. He's an awful person. Guess what they want to talk about? Even though they said they didn't want to talk about it. Their stepfather. There needs some work there. So let them talk and guide them gently. Also, you need to consider that within the first 7 seconds, they're going to determine if you're worthwhile to talk to. Okay? So they're going to look at you, size you up, and determine, okay, this person's a wimp. They're not ready to hear a story like this. They're not worthy to talk to me, or I'm going to spend the rest of the day telling them my story. Okay. You have to think about phenomenon that can happen as transference, countertransference, and resistance. Resistance is nobody likes to talk about hard stuff. Okay? Everybody has their own junk. Nobody likes to talk about it, put it out there. The problem is they need to. They're going to be so resistant and trying to put the topic back on you, like I said previously, and you have to keep redirecting that. There's going to be transference and countertransference where you may have, or they may have feelings looking at you about somebody they know. I'm sure you guys have probably heard, oh, you remind me of my niece Karen. She's a doll. I love her. That's not really a compliment, because now they have ascribed all those personality traits of their niece Karen to you. So that's not a good thing. You don't want to remind them of that person. You want to say something like, oh, I hope those are good characteristics, or something along those lines to kind of redirect and let them know that you're not Karen. Another thing, and I actually ran into this with a student, I guess, it's right when I first started, so about 12 years ago, 10, 12 years ago. She was in a very bad personal relationship that I knew nothing about, and I assigned her a patient who was, to be succinct, he was a wife beater. And that personality trait that she had grown out of, or she felt she had grown out of, creeped back into her. And I found her sobbing in the pre-conference room. Well, I guess it'd be just the conference room after she talked with him. And she told me everything, that he reminded her of her ex-husband and the whole situation, how angry he'd become. And we had a long, serious talk about countertransference and how I understood, and as soon as she felt that way, she should have let me know, and I would have reassigned her. And I appreciated her telling me at that point, because it was still early enough that we could get away from that fella. But it's going to happen. At one point or another, you're going to meet somebody in your nursing career. They're going to remind you of somebody, be it good, be it bad. It doesn't matter. Okay, it's called countertransference. You have to remember that this person is not this other person, and you are there to take care of them. You are there to guide them to take care of themselves. Okay, I think I'm going to leave that one there. There are many different defense mechanisms that patients will use also to avoid talking with you, and you may use them yourself too, because you become uncomfortable during a conversation. It happens. It's okay. Not everybody is able to communicate the way that sometimes needs to be done, and that's okay. okay? Psych nursing is not for everyone. I understand that. All I'm asking for is your best effort. Let's talk about some of these defense mechanisms. Denial. Frequently, if you have an addict and they are seeking treatment, they're not in denial, okay? If they tell you, oh, there's nothing wrong with me, I'm just here because, I use a little heroin, it's time to get off of it. That's denial, okay? Projection is where you actually have something that you firmly believe yourself, and you believe that everybody else thinks the same thing about you. Okay, the example I have is this guy, he's thinking he wants to go out and kill somebody, and he's stating they want to come and get me, they're out to get me. So now, it's different when there's delusions and things involved. So don't think every schizophrenic who's paranoid believes that you were really paranoid or you're really out to get him. Okay, just know that this is a defense mechanism that can be used by some people. It's generalities. Regression, that's where you go back in time to a much safer time. And I do this sometimes in therapy with people. We will regress. I call it bubble therapy, and we'll use a little bit of regression where we'll go back and we'll do bubble blowing. And I have tons of kids, so I have lots of bubbles around my house. But the principle of it is that it involves deep breathing and relaxation. Gentle relaxation, enough to blow the bubble. And it really helps with anxiety. And it can be a useful tool in that if you have someone who goes back and starts, like a 7-year-old who's now, nocturia, she's using the bathroom while she's asleep. There may be some other physical ailments in that she's defending against. Maybe she's being molested. Maybe something's happening stress-wise at school. Those are things that have to be explored, but that's a defense mechanism. Sublimation is where they take a socially unacceptable thing and they make it socially acceptable. Like this guy here, he really wants to just tear things up and destroy them. But instead of going into construction and demolition, he decides to be a surgeon. Okay, so he didn't exactly do well with his decision making as far as college goes, but you get the point. Let's see. Rationalization. I love this one. Rationalization. But the bank has plenty of money, so why don't they give it to me? You have plenty of time. Why don't you just sit down and talk to me? You expect more. My kids tell me all the time, you can drive me to so-and-so's house. You got time? Well, no, I don't have time. I'm cooking supper, doing laundry, and I got to take the dog for a walk in just a little bit. But still, they rationalize. Undoing. You see undoing a lot with eating disorders, and when we talk about eating disorders, we'll talk about purging. And purging doesn't have to be just vomiting. It could be excessive exercise. That's one way to purge. Repression. Freud was famous for this, but like I said, I'm not going to ask you about Freud. I might ask you about repression. Repression is where we'll talk about that tomorrow. You just keep putting it off and putting it off and putting it off until it is possibly a splinter in the basement of your thoughts that causes all sorts of aberrant behavior until it's actually discussed. We'll talk about that later too. I don't want to get too excited about it. Somatization, we'll talk about somatic disorders. That's actually where you have a physical manifestation of your stress. In this case, husband wants a divorce, wife can't hear him. So it's almost like a conversion disorder. Somatization is the broad category. Conversion disorder is one piece of it. Your eating disorders or other somatization disorders. We'll talk about it later. Hang in there. Reaction formation is where you believe something about someone and you formulate a decision on them without any proof. Okay, that's where you walk into the nightclub, the girls in the back corner are laughing and you think they're laughing at you. It's a reaction formation, it's a defense mechanism. Okay? Displacement, that's where you get yelled at by the boss and then you go tell the housekeeper she's doing a sloppy job. Okay, so you're just putting the blame where it doesn't really belong. That's displacement. People do that all the time. My 5-year-old, I didn't do that. That was Tiffany. No, that was you. You're the only one that can pee on my tire. Introjection. This is kind of a scary one, defense mechanism. This is where the individual will take traits and personality parts from a person and integrate them into their self. They become this other person to an extreme. I think of that movie, The Roommate. That's to an extreme. Okay, we all take pieces and parts of who we know, and it helps us develop who we are, along with our own thought processes and where we grew up and who we grew up with. Again, individual, family, environment. When you do something like that, it's considered healthy. You know, if I lived in Kentucky long enough with my friend Lisa, I'd be talking with a southern drawl and I would probably be vegan because that's what she is. We pick those things up. It's okay. But if you do it to an extreme, that's a problem. Compensation. Y'all should know what compensation is. The old joke is that's why he has a big truck. I don't know. Moving on. Suppression and repression are kind of alike, except suppression is you just don't deal with it at all. You suppress it, it's not there. Identification. Nurses usually are very much guilty of this, and this is where you can cross the line in your professional care of your patient. You have someone that you're taking care of and they have throat cancer. And your mother had throat cancer. And now this person, you can identify, they say, I can't swallow. Oh, my mother couldn't swallow like that either. It was awful. I can really feel for you. Let me get you something to help you swallow a little bit easier. You identify with them a little too closely. So maintaining those professional boundaries is very, very important. You want to make sure that you're not crossing the line. You can lose yourself in that, and then you can burn out real easy. It's not a good way to go. Or humor. I like this one. It says, well, one of the benefits of coming out was my mom finally quit setting me up with all her friends' daughters. Humor is okay. You have to be very careful with humor, though. I remember a guy who came in, his name was James. Probably 70-ish, 71, younger guy. And I was the charge nurse on days. I was in my 20s, thought I knew what I was doing. And he didn't have a port. I was on oncology, and he did not have a port yet. And so we had to start IVs for his chemo. And he had fabulous veins here and here, okay? There and there. And those are the two that I went for. Now, I was good with IVs. I could put them in your thumb, you know. Back in the day, I was a good thing. But we would, and I would just move right up the vein. If it sclerosed or it blew or whatever, you just move up the vein or, choose something like that. Anyway, James came in, and we'd had built a relationship, which is one thing you do in chronic disease is you build relationships with these people, therapeutic relationships that span time, which is why I'm a chronic disease nurse. I could never do ER, ICU, and things like that. If my patients can't talk to me, I can't build a relationship, and I'm not a happy camper. So, but James, he was grumpy, and he was really, I don't know what he was grumpy about. It was one of his kids was doing something stupid in college, and he was grumping at me. And I stopped, and I looked at him, and I said, James, you know me, and I know you, and you know I'm here full time. If you don't change this grumpy attitude, then we're going to tangle. Oh Lord, that man laughed and laughed and laughed. I didn't think he'd ever stop laughing. It was so funny because I was trying to start his IV and he was just rah, 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 rah. Well, he stopped and we got the IV and we went on from there. Be very careful when you use humor though. Unless you've built that relationship, you don't really know who that person is. They don't know who you are. They can take you all wrong. Okay? Some things to think about. Therapeutic use of self, using yourself as a tool, verbally and non-verbally. Boundaries, 3 to 6 feet are considered appropriate therapeutic communication boundaries. They're social boundaries. Intimate boundaries are involved in an intimate relationship. Personal boundaries, that would be close, like a friend of mine. I would hold his hand, or he would have his arm around me. That would be a personal boundary. It'd be acceptable. Public boundaries is if you're coming to see a speaker, you would maintain a public boundary. Self-disclosure, don't do it. Just don't do it. Not with the mentally ill. It's not a good thing. They, like I said in class, will Google you. If they know your last name, they will Google you. They will find out where you live. They will come and locate you. I had that former patient of mine show up at my husband's funeral. So just don't tell them about yourselves, okay? If they say, oh, how many kids do you have? Just kind of think to yourself, okay, they're trying to redirect the conversation back about me, and it's not about me. And that's what you can say. You can say, I'm sorry, this conversation is not about me, it's about you. And we need to regroup and come back and talk about you. Okay. Gifts. I always take homemade gifts, always. If I had a depressed patient, he was an artist and he liked to draw pictures, and he drew a picture when he first came in, and it was all colored black and dark blue, and it was very sad. And when he left, he drew me a picture of a rainbow and the sun and birds. And so I always keep personal gifts like that. Monetary gifts, no, we're not in it for that. They want to give you the items that mean the most to them. I'd be thinking they're trying to kill themselves or thinking about that. So just always question. Like a candy bar, like at Coleman, they say don't eat the donuts because the guy gets them out of the trash bin. Don't eat the donuts, but accept it and walk into the other room before you throw it away. Candy bars, remember we talked about candy bars in clinical. If they're sealed, we're good. If they're not sealed, we got trouble. So kind of think along those lines. Touch, reassuring touch to a shoulder is acceptable. An upper arm is acceptable. I would not touch anybody on their legs, their back, their hands, their face. And until you are really wise in nonverbal communication, I would trust that you guys wouldn't touch them at all. Okay, you just don't have the skill set yet to know if you're sending the appropriate message. And I don't mean that as a diss. I just mean it as in you've not been around the mentally ill long enough at this point in your career. Well, maybe some of you have, but most of you probably have not, to know what's acceptable and unacceptable. And values, and realize that your values could be different than theirs, and accept who you are. Go with who you are. It's perfectly okay, and accept who they are for who they are. Okay. Some things you might be afraid of, and I have heard this so many times. I might say the wrong thing. I'm here to tell you, my friends, you will, and it's okay, because I have. It's fine. You're not going to kill them. They won't go commit suicide unless you tell them to go commit suicide. And we talked about that. Don't do that. But they're not going to die if you say why. Okay? You're going to say the wrong thing. Just learn from it. Move on. Knowing what to do. Being rejected. That's happened too. We've had patients who said, I don't want a student. That's cool. We can give you somebody else. There's lots of patients who want to talk to you. Doesn't have to be that one. Asking personal questions. Remember, redirect to them. Handling bizarre, inappropriate, or sexually aggressive behavior. Like I said, at St. Rita's, we have a lot of people who walk around without the clothes on. You just ignore it. You remind them, say, you need to go put clothes on, we're in a public setting, let me assist you, and guide them back to the room so they can get dressed again. Don't belittle, don't make fun, don't do, oh my God, don't do shock. Just be very matter of fact about things. Handle feeling unsafe. You may feel unsafe where you go. I'm not going to assign anybody to an unsafe patient. And I can guarantee you that there isn't a single adjunct that works in this course that will do that. We look at all our patients, we make sure that they are acceptable. They're not antisocial personalities. They're not violent offenders. They're not angry, hostile people. We won't put you through that. At the same time, I'm not going to coddle you. I'm going to give you challenging situations. You're going to be out there. You're going to need to know how to use technique. So if you haven't read them already, read them. If you see somebody you know on the unit and you feel the need to reassure them that you are in a clinical situation and that their privacy is protected by HIPAA, please do so. I actually had a very good friend that I did not know have a depressed break and ended up, I knew I hadn't heard from her in a few days, and then she came walking on 4E. I went and I assured her that her confidentiality was protected, that I wouldn't be talking to our other friends about her, and that I would come visit her later without my clinical garb to be a good friend and support to her. So if you know somebody, you know somebody. It's just the way it is. Deal with it. Move on. Be aware of your own belief systems, potential conflicts, your need to accept your patient regardless. And the reason you do the journals, you do journals just about every week, is self-awareness. People always laugh and they say, why do I have to do this journal that says, some sort of humor or awe-inspiring moment of my day? And well, I'll tell you why. Because we live in a world where there is not those things, or they're unnoticed. And that can take its toll on mood and behavior. And you guys are in a field where you're going to be inundated by other people's moods and behaviors. You're going to be ruled by them. You need to learn to recognize your own. I hope that makes sense. Role play. Can't role play here, obviously, but guaranteed. I'm going to have you in class and we're going to role play. Mr. Moore, it's going to be you. And probably in my other class, one of the sisters. Yeah, that should be great fun. Anyway. Oh, and if it's my LPN cohort, who am I going to pick on in there? Oh, Ashley. You're on it, honey. Anyway, when we get there. Moving on. Psychosocial assessment, the actual assessment. You'll see on your evaluation forms that we will mark that you've done a psychosocial assessment or mental health assessment. It can be done by the nurse and includes a psychiatric history, a personal history, physical exam, psychological exam, okay? You guys are doing all that. One thing I ask you to consider, and this is kind of big for me, is I want you to think about mental illness as being part of the whole person, or your mental health being part of the whole person. Frequently, if you have someone who has a mental illness and they also have a comorbidity, say hypothyroidism, it's a big one. They have hypothyroidism and they have depression. You're going to want to look at both of those things and you're going to say which one is the real problem with this person's mood right now. You're going to test T3, T4, TSH, just to see if that's out of kilter. Because if those are out of kilter, the depressed mood is going to be exacerbated. Okay. This last slide actually has neurological disorders like stroke, Alzheimer's, Huntington's, Parkinson's, cancers, hepatitis. All of those can mimic depression. So you have to rule those out first. Then you go on to anxiety. Again, we have Alzheimer's, neurosyphilis, septicemia, hypoparathyroidism. All of those mimic the signs and symptoms of anxiety. Psychosis, medical conditions, temporal lobe epilepsy, migraine headaches, encephalitis, alcohol withdrawal, all of those look like psychosis. So we don't want to label people and say, oh, he's schizophrenic. We want to make sure before he's diagnosed as schizophrenic that they have done a brain CT to make sure there is no tumors up there. It's kind of a big thing. But I want you to consider, if you have somebody who has depression, do they have any of these other ailments? Are these other ailments the cause of the depressed mood, or is it true depression? If they have anxiety, if they have psychotic features, are they related to something physical that we can repair? That's all I got to say on that. And that ends lecture 1. We're going to go right into lecture 2 here. It's labeled various topics in your PowerPoint presentation. So if you want a few minutes to get your various topics out, I'll give you 5 minutes here.